coronavirus pandemic has created an urgent need for providers to have practical guidance to accomplish safe tracheal intubation of patients, minimizing risk to both patients as well as care providers. We extrapolate from the SARS epidemic that individuals involved in these procedures are at a substantial increased risk of viral transmission.
Well, hello everyone. My name is Dr. Stephen Gleich, and I'm a consultant at the Mayo Clinic in pediatric anesthesiology and pediatric critical care medicine. I've worked with Dr. Sandifer as well as our other colleagues, Dr. Daxon and Dr. Niven, on our manuscript entitled Practical Guidance for Tracheal Intubation of Patients with COVID-19.
And I am Dr. Benjamin Sandifer. I am a consultant in the Department of Emergency Medicine at Mayo Clinic in Rochester, Minnesota. In our manuscript, which is a commentary published in the Mayo Clinic Proceedings this month, we outline our institution's approach, which is multidisciplinary in nature, in which we synthesize the available empiric evidence as well as expert guidance that's currently out in the literature in order to generate practical guidance for our frontline providers. Two overarching goals informed everything that we did at our institution: patient safety and safety of the patient care team. And three guiding principles emerged from the evidence that's currently available in the literature. Number one, minimizing aerosol generation. Number two, maximizing first attempt tracheal intubation success. And number three, minimizing exposure of the care providers.
We used an iterative process to create guideline recommendations which were applicable to each specialty group and avoided focus on niche interests which could create confusion in varied care settings. Now, I want to direct your attention to the manuscript. Figure 1 represents the culmination of these steps and serves as an overarching guide at our institution. Particular attention was paid to areas where novel care processes exist, such as the early use of a rescue second-generation supraglottic devices to minimize mask ventilation. And remember, mask ventilation may also be aerosol generating, as well as limiting such things as ventilator circuit disconnections. Figures 2 and 3 represent new procedural checklists for bedside guidance, which adhere to our overarching principles. And figure 2 relates to adult intubation, and figure 3 relates to pediatric intubation. Now, while the vast majority of the same considerations apply to children, there is the classic saying in pediatrics that children are not just little adults. And certain aspects of this hold true with endotracheal intubation in a child with COVID-19 respiratory failure. And I want to point out two main areas in our checklist that differ for children. The first relates to pre-oxygenation before intubation. We recognize and note that the age of the child and the developmental status may preclude how well a child is able to be pre-oxygenated. Some children may simply not tolerate a mask or other device being placed on them. And in addition, they have physiology that predisposes them to rapid desaturation while apneic. And this is almost certainly made worse by COVID-19 infection. As a result, we've highlighted the fact that bag mask ventilation may be required in children while taking the necessary precautions. The second difference for children relates to the intubation technique. While video laryngoscopy is the preferred intubation technique in adults with COVID-19 respiratory failure, there are certainly fewer pediatric providers who may be as familiar with video laryngoscopy. And consequently, in order to adhere to our second core principle, and that is to maximize a first attempt success, we recommend that the best device, such as direct laryngoscopy, for each provider should be used in order to maximize that first attempt success rate. This isn't a time to be trying out a video laryngoscope for the first time if a provider has never used one before.
We also believe that it's critically important for each institution to develop a robust shared mental model for tracheal intubation of patients during pandemic. There are multiple providers from multiple specialties who are involved in these procedures. This ranges from anesthesiology to emergency medicine, critical care medicine, ENT providers in both adult and pediatric specialties. Additionally, nursing providers, respiratory care colleagues, pharmacists, all are involved in these processes. At our institution, we spent a tremendous amount of time and effort being sure that all individuals with a stake in this process were at the table in order to be sure that we had broadly applicable and yet discrete, easily followed steps for our care process. At the end of the day, we shared our process and our novel tools that we created in multidisciplinary fashion in hopes that it would serve as a useful guide to others at other institutions as they go about similar processes. Thank you again for taking the time to watch this brief video, and I hope if you have interest, you'll take a moment to review our manuscript in this month's Mayo Clinic Proceedings. And I just want to take one last moment again to express my sincere appreciation to all of our multidisciplinary colleagues who were involved in this process.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.